I think the real master on tibial eminence fracture is sitting down there, Shetal. All right, are we okay to run? Why is it so small? It's not full screen. Is it okay? I can play the video, is it? All right. So this is the anatomy, the intercondylar area between medial, or only 5 minutes, okay. So I quickly go through this. So this is the area where you know about, the ACL attachment there, where you have the in between the lateral and medial eminence. But what's so important is this thing about the AM bundle and the PL bundle that adult surgeons always talk about, and they are named according to the area where the tibial eminence, where they are inserted to. So this is the AM bundle, which is quite isometric throughout, and AM. So whenever the knee is flexed, the femoral attachment become more horizontal, the AM will tightens and PL will relax. So this is the one. But coming to kids-wise, really a younger group of patients between 8 to 14. In the Meyer and McKeever, which originally published this, a lot are bicycle injuries, but now a lot to do actually young kids participating in sports, and in Singapore a lot of football injuries. So they behave a bit like adult ACL. When you get your ACL injury, at the same time you may have a associated meniscus and also osteochondral fractures. So here you go, Myers-McKeever classification. If anyone interested in this, you have to learn this type 1, 2, 3, and then later being modified, you add in type 4, where you get displaced and comminuted, all right? So by and large, for type 1 and 2 would be non-operative, and then the higher type is the one that we operate. And this would be a type 2, meaning you are, almost like supracon, like that. So basically your posterior hinge is still attached. So it just anterior open up. So by this, so what you do, your treatment is you do a nice so-called extension cast. But a lot of time you can see that the gap still there, and even then you do your MRI, actually you found that, this is not as perfect. But yet, a lot of parents are not very keen for an 8-year-old to have surgery. Then they say, okay, then we carry on doing this in a cast. So we try not to do this group. We only do those truly type 3. So type 3 wise, how do you fix them? Two-way, either you open with a scope, open with a screw, or sometimes also a screw with a so-called scope assisted, or you use a suture. So screw versus suture. Screw, you worry about injury to the physis. Suture, better go faster. Okay, suture will be more demanding. So let me give you some example, and then and then basically this poor kid had you can see that on X-ray, very obvious, the whole fragment come up. But I think MRI is really interesting. For those of you at the back, I try to give you an animation on this. You can see the whole ACL is still there. But first thing you look, there are a lot of fluid bleeding at the suprapatellar pouch. And next thing you see the anatomy of tibial eminence like that. But you can see in between there, you look at this, there's a very black thing there. It's called ACL. But unlike ACL tear, this is perfectly intact, all right? But the whole tibial eminence became higher. Okay, only 1 minute, all right? So we try to do scope, and I hope you can appreciate this. So very important, you clear the fracture site, but usually very bloody because it's avulsed off. So you took a while to flush away all this bleeding, and then you can see the meniscus coming your way as well. And having done all that, we are a bit clearer, less bleeding, and less cursing. Then I start drilling a wire through that. And this is what you do to get into the both sides of the ACL where you should be. So you drill another drill tunnel. So basically this is where you're going to pass your Arthrex Lasalle suture, meaning the one that you guide later your suture. Okay? So And this is where the suture you are going to later going to tie over the ACL. Oh no, okay. Sorry, grab it. But never mind, quickly. More important, next slide. This is the one that after the Lasalle suture, the PTS being passed, and Alaric hates this when he did with me, because always what a mess, you know, the suture passing, and then how you get your Ethipon suture also to pass over together, and things hasn't changed. They still crisscross a lot. So because you really try to pass both, and to a while, basically you use that to wrap around the ACL bundle, and in the end you grab it and then you try to later really pull it down. Okay, quickly, that's next one. And then you grab another one to basically tie all of them down. Okay, so this was like, you can see that you drill all your tunnel, and finally, where we tie over the whole ACL come down distally. So you can see that the whole ACL ACL ligament itself is all intact. Sorry. And this is the post-op X-ray. I think it looks more reasonable now because the whole tibial eminence has come down. And this is X-ray 3 months later. It has not displaced upwards. Okay, so alternatively, you can also do it this way, but you can see that you really have to use a very, very short screw. And I found that, you know, the angle I enter and the scope is really, really acute and tight, so not as easy. Actually, I actually found that after a bit struggling, but your arthroscopy suture method is actually superior. So thank you very much.